with the absolutely great presentation of Professor Nekufar. I really enjoy it. Professor Nekufar, most welcome. Thank you for taking time to joining us again.
Hello, how are you?
Hello, most welcome. Thank you for
joining us. Good to see you, Dr. Mutawassalam. Thank you very much for all of your effort for this course, which I personally really enjoyed from each part of that, to be honest with you. And I think we are almost going to the end of the course somehow. Yes, am I right?
Yes, that's right. It is the last session. I had a brief explanation about this session, but at that moment, many of our participants did not present. Do you let me to have a very short introduction of this session that you start?
Of course, please.
Thank
go
you.
ahead.
I'm sorry. As all guys,
do you want me to unshare the screen for you?
No, not at all. No, not at all. You will enjoy a very beautiful butterfly there. That's in a balance with the two small stones. It's very delicate picture. I enjoy it. Thank you. I appreciate it. Hello again to all guys. Because some of our friends were not they did not present at the time that I had a short introduction. I would have a short introduction again about this session. I would like to welcome you all to this last session of this virtual program. A big thank you all for following our all sessions. I'm sure you had an absolutely big growing knowledge about the evidence-based approach, and you will follow all the guidelines and the information that our fabulous presenter had during these 6 sessions in order to apply it in your life, in your research, in your practice. And I hope you do it. But definitely we know that we need to practice on it. Do not forget it. And we need to review all this information we got in order to not forget it and review it and apply it in our life, in our practice and research. And the previous session, if you remember, it was an overview of the critical appraisal that was presented by 2 fabulous lecturers. If you remember, Professor Babu and Jakub. I really enjoyed it and never forget it. I want to listen to the lecture hundreds of times in order to hack it in my mind. Anyway, and today I lectures Professor Nekufar, Professor Shamshiri, and Professor Khami. And you have known all this respected lecture during the workshop. I don't want to introduce them again. You have known all this respected lecture. And Professor Nekufar would have a talk about the hierarchy of evidence, which is very important, and interpretation of evidence that will be presented by Professor Shamshiri. The workshop will be finished with a short question and answer, and at the end, will be finished with a sum up of the entire purpose of this workshop. Okay, Professor Nekufar, the stage is yours, please. We are waiting. The stage is yours. We cannot hear you. You're on mute. Okay.
Thank you very much. Hello, everybody. And I don't know, I should say good morning or good afternoon or good evening, because we are very happy to have participants from around the world. I'm actually in my office, in my surgery. So therefore, I'm ready to go back to the clinic after I finish the session, which is the reason that we are here and the reason that we discuss about the clinic. Why we are here? Because we want to balance between our knowledge and give the service to our patient. This is our duty, and this is the most important goal of this type of gathering. We want to give a good service, a good care to our patient. And the reason that we discuss about the evidence, about the balance between the technical quality of a clinician and background knowledge of all the publication, including the evidence-based publication and laboratory-based publication and everything, is because we aimed to give good service to our patient. I'm sure you agree with me about that. One of the things that I'm very keen to have, and I think if I want to criticize our course, is the lack of interactive communication between the participants and whoever is going to give a lecture. I was actually in the lecture with Professor Venkatesh Babu. He is one of the world authority in this field. And he asked a lot of questions, and the only person who answered was Dr. Mutavassilian. I think she is going to be a very, very famous evidence-based dentist very soon, because she answered all the questions. And today, I'm very keen, if possible, to ask you again, please turn on your videos and stay with us, because then we can see each other in a very good way. And then I feel, as a person who is teaching for half an hour or 45 minutes, to have some of my students around me. Actually, now we are 4 of us. We are all panelists of today. So we are all of our videos open to you, but we need actually to see nice faces and familiar faces from our students to give back good energy, a good positive energy to us, to speak in a very interactive way. And the reason that we choose actually Zoom platform is this. Maybe we can run a clinical trial by the lead of Professor Khami and Professor Shamshiri about the effect of a good infrastructure of participant engagement in this type of communication. Because the thing is, I don't know actually my participants are already engaged or not. So this is the issue for this type of communication. I just finished around half an hour ago, I just finished another 1.5 hour lecture about ethics in endodontics. And in that one, the communication, even the quality of the connection wasn't very good like the one that we have now. This is very good comparing to that. But in that one, we had a lot of interactive discussion, which helps me to learn from my participants, from my friends that they gather them under this umbrella of evidence-based. By the way, let's go and this slide was the last slide from my first session, from my first presentation, that I give you some information about how we can use the evidence in the clinical field, because this is the most important things that we need. When I have a patient, I should think about that. What is my background knowledge about that? What is the technique that I can use? And which technique is going to be more efficient? Which technique is going to do better performance with less chair time? Something like that. So I need the answer from the literature, and I don't know what type of literature I can trust. Then it comes to the hierarchy of evidence. Speaking about the hierarchy doesn't mean the hierarchy, for example, of royal family. We are not speaking about that. However, somehow this hierarchy indirectly gives us some sort of message from that type of hierarchy that we have in army, or we have in royal family, or something like that. That some people are workers, but some people are leaders on the top of this pyramid. I'm not speaking about is it fair or not? It's not my job to do that. But speaking about the hierarchy of evidence, that means when we want to decide, when we want to do something, we shouldn't use what we have at the base of this pyramid. What we have at this base, which is green here, like background information or expert opinion, it is necessary. I will show you some very important things about that. It is definitely necessary, but it is not adequate. The problem is that it is necessary. It is mandatory to have enough background information, for example, about anatomy. Can we do something without any knowledge of anatomy and histology? Obviously not. Can we do any type of treatment in the field of medicine and dentistry without having the knowledge of, for example, without having the knowledge of immunology? I'm sure it is not possible. So speaking about that with a medical doctor also, it is same. Medical doctors cannot do anything without having enough knowledge and adequate knowledge from basic science. But obviously, they cannot rely just on the laboratory studies. They cannot rely just on the pharmaceutical studies that a chemist or a pharmacist give them some information. So we as dentists have similar situation because, for example, speaking about endodontics, which is my specialty, speaking about comparing one visit root canal treatment to multiple visits. Okay, can you help me and tell me, should I multiple visits or should I do one visit? So I want to decide. Today I have a patient. Right now, after 1 hour, I want to start my first patient. And the first patient, it needs a secondary treatment or as so-called retreatment. Okay, can I finish that in one visit or not? So that comes to the evidence. I may say that I have enough information and I have enough ability and enough expertise to do the root canal treatment in one visit. But if it is a secondary treatment, comparing to primary treatment, can I do that in one visit or not? So then I need to go to the literature and find out and extract the data from the literature. Inside the literature, I may find something, but then it goes to the type of studies. I think during this course so far, during this 5 or 6 weeks that we have with you, we already covered the different types of studies. But now what I want to emphasize on that is, okay, speaking about different types of study is not enough. It's now important to say that which one is more powerful, which one is going to give us some information that we can use them in clinical situation. We need to be very careful. Each of them may have disadvantages and advantages, and each of them can do different types of job. So let's go further and see what we can do about that. So I start by the base of this pyramid, which is clinical expertise. Me as a clinician, and most of you as clinician, may say that, okay, what we have done during 6 or 7 or 5 years of our study in dental school, and even after, if some of us becomes a specialist, what we have done during that 7 to 10 years, just clinical treatment, and increase our clinical expertise and clinical experiments. Sometimes we did something wrong, so we learn from our mistake as well. But we need to do such a thing systematically to give information from clinical expertise to make it as to do that competently without any problem. But what is the way to do that? Then it comes to the hierarchy of the evidence. Okay, can we do something without clinical expertise? Obviously not. What I said here, which is a very important message to us, is neither individual clinical expertise nor the best available external evidence works very well alone. So somebody from outside of our field cannot come to our field, read all this evidence and start doing something. No, it's not possible. It's like driving. When we want to drive, we need to know how to drive. We need to know how this machine works, and we need to know all the rules and all the risk even. We need to know the risk of different, for example, roads when we go outside and blah, blah, blah. But can we start driving straightforward after reading all the books, all the evidence about driving? No, not at all. We need that clinical experience as well. So we need to sit and do preclinical studies and post-clinical studies and a lot of things. We need to do follow-up. We need to do the job inside the clinical situation. A doctor without the clinical experience is nothing. We need clinical experience. But this clinical experience, without sufficient and adequate evidence, also cannot work very well. Okay, Without the best external evidence, clinical practice easily becomes out of date. That is the problem. And treatment efforts will go beyond adequate. It is adequate word is very, very important. And we need to be very, very careful about that. We need to keep ourselves up to date. I remember that from the first session that we had with Professor Mohammed Khami, who is also the manager of the whole course, and we should thank him as well. He said that there is an explosion of information and we cannot keep ourselves updated. But we need to keep ourselves updated by using maybe second-hand information from the people that they already did the job for us and put everything together and give us some evidence or put them in a critically appraised, mini-critically appraised publication and something like that. But without that, without this external evidence, when I'm saying external evidence, I'm speaking about the evidence rather than the one that we can get from the clinical situation. Without that, we cannot do anything. However, as I said, neither individual clinical expertise nor the best available external evidence works very well alone. So we need both of them. We need that butterfly on one side and all the sun on the other side to make this balance to work. I'm sure Dr. Mutawassilan is going to enjoy from this slide again. So let's go further. So if we want to do such a thing, we need laboratory. Yes, please, go ahead.
May I ask a question? I'm sorry to disrupt you. About the external evidence, do you mean the literature?
Yes.
Do you
yes,
mean the literature? Okay.
It's not just the literature, because again, speaking about the literature, as you remember, we need also somehow to look at the literature, criticize them, evaluate them, put some of them outside our field, and say some of them is not good, for example, or are they good or not. We should filter the evidence as well. Yeah. But sometimes the authors do the job for us and they publish something that we call them second-hand evidence. And this second-hand, when I say external evidence, I mean they are not our clinical expertise. Yes. We are not going to get them from the clinical area. But in the clinical, when you put your burr on the surface of a tooth, you learn from that each time. It's like a pilot that if they put in the logbook that, for example, they had another hour of flying, they give them more experience and they rank them higher and higher and higher. This is the clinical experience that we need. But this is internal. But we need some external information as well. The external information comes from the literature, comes from the experiments that other researchers may do and report it, and sometimes they don't repair it. Then it goes to that gray literature that Wenke addressed them as well. I cannot judge on type of literature at the moment, but I'm going to speak about the different types of a study to show that even different types of a study, they have different level of, they can give different level of information to us before we overgeneralize them and before we use them in the clinical situation. That's a very good question. Thank you very much. By the way, back to that. So as you can see here, to balance this, first we need the laboratory-based studies. Without these laboratory-based studies, especially in dentistry, without that, we cannot do anything. We need that. We need to know how to deal with such a things based on the information that we get from the manufacturers, we get from the studies that people in dental material science may do that for us. Obviously, we can call them in vitro studies. In all of this in vitro and sometimes ex vivo studies, they may do a lot of things that we put them underneath of the level of this pyramid. We put them under the base of this pyramid. Even they cannot go on the top level, but we need them. Speaking about this hierarchy doesn't mean that we are not going to use some of them, or we are going, because some people may claim that we are going to put some of them inside the bin. They don't have enough value for us to use in the clinical situation. No, that's not true. each individual publication, they have their own value. I remember again from the course that somebody asked about, can we run a systematic review on laboratory studies? And the answer is yes, we can. But again, the level of this evidence is not very high. That is the only thing. We can use that evidence as well as we can use other evidence by putting our background knowledge in this pyramid, and because this guideline said that, because that systematic review said that, I did this job, and if it goes wrong, then studies, obviously not. These days we heard a lot about the start from the laboratory based, working on, for example, some cultures that comes from tissue, that comes from cells, that comes from bacteria and other things, and then animal studies. Again, we are speaking at the base of this hierarchy, at the base of this pyramid. And then it goes to chemistry and making something in the laboratory, make some medicine, some technique, some material. And this is all technical. But again, without this technical and without using these techniques in the lab and in animal studies, we cannot go to the clinical level and to the clinical trial. Then it goes to the clinical level. Again, for the clinical level, there are different levels as well. Why? Because of the number of variables that we encounter. The number of variables and the type of variables that we have, we need to be very careful about the design of our study. One of the bias that we should be very careful about that, the design bias. So when you want to do something, first of all, you need to define your aim. You need to define your goal. And then according to definition of your goal, you need to decide which study is going to answer to your question. So first, you need an aim. Then you need a good question, which is sometimes very difficult to find a good question. Then you find the good question. Now it's time to go to the design of this. And then you are able to design a good study and use the proper study, put that in the hierarchy of evidence, use that and the level and the power of that study. Don't overgeneralize it and don't underestimate it. So we don't underestimate any type of these studies. We use all of them at the level that they are in. So one of the very important information that we need is the data of internal anatomy of teeth, of the data of anatomy, histology, immunology. I put this micro CT scan just to show that how the technique can help us. For example, again, in my specialty as endodontist, without having the knowledge about the internal anatomy, I'm not able to remove the source of the disease from the root canal system. So I need the information from the laboratory studies to look at the internal anatomy and the complex internal anatomy of the tooth to be able to get rid of the source of the disease. You know that. Are you sure that you need to get rid of the internal tissues and internal inflamed or infected tissues from the root canal system? Then it's time for me to think about it. And you can see now there is a big paradigm shift to vital treatment, because many people accuse us of resectional treatment rather than regenerational treatment. So looking at that, this becomes a type of combination of the background knowledge and the clinical expertise and the clinical evidence. So when it comes to the clinical evidence, we need to compare different techniques with each other that we are going to discuss about that. But first, we need this information, then we use information to go further and further. What is this? Can you recognize this note? Do you want one of them or huge number of them or not? Dr. Motawassilian, are you going to pay us at the end of this course? Something like that?
I'm sorry, I cannot get my paid.
It is free for us even. Oh my God. So this is the queen. And this is a pound or a 20-pound note. I want you to concentrate on the necklace of the queen. What's the point? What is the relation of that to the clinic? And what is the relation of that to the evidence? Let's have a look. What am I doing? I'm going closer to the necklace. Can you see something in the necklace? Can you see something here? Yes or no? Can you see, Dr. Shamshiri, can you see something? You have very expert eyes by looking at the money. Can you see something?
20 has been written.
Not yet? Okay, let's go further. I'm using my microscope. I'm using operative microscope in endodontics. So I'm going further and further and further to show you that on the necklace of the queen, there is number 20 alphabetically and Arabic as well. 20, 20, 20, 20 to make sure this is a genuine 20-pound note. So how could I find such a thing? Look at that. I just put my microscope and I go further and further. What am I trying to tell you is the importance of microscope as a technical background. Look at this guy. Do you know this guy? This is young Nakufa. I decide to go back to the laboratory work and train myself for the use of microscope to be able to say that I am now competent enough to go inside the root canal system. Without this microscope, you are not able to find the second mesiobuccal easily. You are not able to find 5 canals in the lower molar, and you are not able to repair the perforation and blah, 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 blah. If you tell me, okay, do you have any evidence for that? My answer is, I'm not sure. I try to find some interesting evidence about the effect of microscope on the outcome of root canal treatment, and I couldn't find anything. Without microscope, also an endodontist can do the job, yes. But which one is more accurate? Still, we don't have evidence. Let me ask you another question. You know the importance of rubber dam in endodontics, don't you? Importance of rubber dam is very, very obvious. Without rubber dam in endodontics, you cannot do anything. And you know that if one of my students in the department, endodontic department, try to do root canal treatment without rubber dam, we fire them. We send them outside. And we know rubber dam is very important. If Dr. Shamshiri asked me, do you have any evidence to show that the importance of rubber dam? What is the answer? No. I don't have any evidence to show you that rubber dam is very important because it is not ethical to run any study without rubber dam. And it can apply to any type of evidence that we cannot produce those evidence. So be very careful. Don't use evidence as a gun against the clinician. Clinician may do something without knowing or without having enough high-level evidence in the pyramid, in the hierarchy of evidence. So you may say that, okay, usually when we are speaking about the hierarchy evidence, we should just discuss what is the difference between the cohort and prospective or retrospective cohort or blah, blah, blah. You are more expert than me about that. But what am I trying to say? What am I trying to give the message to our participants is to be very careful, because we as academic may sell something to you that you are not able to distinguish between true or false. We cannot produce high level of evidence for all the questions that we have in the clinic. If we have a rare, for example, condition or rare disease, then we are not able to run, for example, a randomized clinical trial or a huge number of cohorts, for example. So therefore, we need to, after we increase the level of our knowledge, we need to increase our skills as well by using different types of instruments, different types of technique, and try to improve our competency to do the job. These images actually before the pandemic, so I really miss this time that we did our job in this way. But nowadays we are under a lot of protection and our job is very difficult. But now you can see I'm doing a surgery by using the microscope and by using the micro technique. Do we have any evidence to show that if we want to prepare the retro cavity when we are running an apical resection, it's better to use ultrasonic tip or a burr? Do we have any evidence? No, there isn't any evidence because it's not able to produce any evidence. So this is my take-home message to you, to tell you, you need some special technique, some especially laboratory, some special animal studies, and all of them are valid, but you need to know their validity and you need to know their level of evidence in terms of hierarchy. Look at that. This is the third mesial canal. So can you find such a thing without microscope? Very difficult, very difficult. Second mesiobuccal of upper molar, very difficult. And I'm trying to show off myself as well. Therefore, you can refer your difficult cases to me. Don't worry about that. I can handle that. But if something like that happens, this is an accident of pushing sodium hypochlorite outside the root canal system. Why this happened? Because without clinical expertise, patient care will suffer. And today because we are speaking about the evidence-based dentistry and we emphasize enough on evidence, somehow I want to speak against the evidence. Not against the evidence, but I want to speak in favor of clinical expertise as well as the evidence. None of them alone is enough. None of them alone is adequate. You cannot drive based on reading the book. You cannot swim based on just reading the swimming techniques. You cannot. And you can, yeah, you may say that, okay, the effect of temperature on the speed of swimming, and you compare two groups in different pools, one of them 20 centigrade, the other one's 30, and the group in the 20 centigrade definitely can swim faster. What's the point? Can I swim now? No, I need swimming expertise. So clinical expertise is that. Without clinical expertise, patient will suffer. And on the other hand, without evidence, you are not going to have enough clinical expertise. That is the important things. And this is the balance. See, this is another harm, another suffer. Because the dentist who did this job, oh, look at Dr. Mutawassilian. You gobsmacked Dr. Mutawassilian. I can see that. Why? Because without clinical expertise, patient care will suffer. You may say that, is there any evidence to show that do we need to fill the root canal system without, before placement or insertion, a post inside the canal? I don't know. I tried actually to make an evidence for that, but I use animal studies, just animal studies, because I'm not able ethically to leave the canal empty and then insert a post inside it. Or is there any evidence to show that if I use larger post comparing to a smallest post, there is no evidence? Because we cannot make any clinical evidence. There are some huge number of laboratory studies that confirm the idea. We can do the systematic review on them as well, but we cannot overgeneralize them somehow too. So far, I think I emphasize enough on the level of evidence and the importance of evidence and the importance of clinical expertise, obviously. But the first level of the evidence somehow now started, case report. After we finish the background knowledge by having enough basic and everything enough and adequate, then it goes one level up, case report. I did the job very well. So I showed you. So I show you this. I remember that. Okay, let's review the case report first. This is a simple method of clinical research and try to show other clinicians about the technique, how to drive, how to swim, difficult case. Usually, it shows unique aspect of a disease or outcome of a new technique or unusual features of a disease or of a technique, obviously, or outcome of a therapy, just one therapy. I did this, it works, that's it. So now it comes to very important clinical question. If you leave it alone, you think it's not working? We don't know. If we have caries, and the caries is very deep, if I show you that I remove everything from the root canal system and it works properly, patient didn't suffer from any pain, you may say that, oh, wait a minute, why you remove everything from the root canal system? You may put something as a lining, as a base, and repair the coronal part, and that may work as well. So this is the main disadvantage of a case report of a very, very good clinical job. Okay, you did a very good clinical job, but on the other hand, you should think and say that, okay, if I didn't touch that, maybe the body itself can repair also the situation. So this is one of the main disadvantages of case report. I showed you this very interesting case from Mahmoud Rabinejad. That was a necrotic canine that Mahmoud Rabinejad filled by the first prototype of MTA, and this regeneration happened. And unfortunately, I, as a young dentist at that time, and I'm still young, by the way, as a young dentist at that time, I followed that and it didn't work. Then we find it out by one case as a case report, even such a case report published in a very good journal with a high impact journal. We shouldn't overgeneralize a technique based just one case because there is no control. And the most important control is nothing. We should do something and compare that with nothing. Then compares the outcome. If I show you that, if I don't do anything, and if I do something, and I compare these two to each other, and at the end I show you that the one that I did something works better than that, then it is good. But if I show you that I did something and it works, okay, what's the point? Is it clear? Okay, so let's go further. Let's ask our participants now to help us. Definitely, I'm not going to ask Dr. Motawassilian to answer to this question. And definitely Dr. Khami is not also eligible to answer my question. So I'm going to select somebody. Let's ask Kazan Omer Abdur Rahman, or maybe Manije Mohammedian, any of you. I ask both of you, Manije and Kazan, to unmute and tell me what you can see in this. Okay, go ahead, please. Any of you, whoever wants to answer, can raise their hand. Otherwise, I'm going to turn on your microphone and ask you to speak. Dr. Ahila, please go ahead. Dr. Ahila, no answer. Mike Agbaid, if I pronounce your name correctly, please. No. Maybe the admin can, okay, somebody tried to turn on the microphone. I think it wasn't successful somehow. It looks like that it's not working somehow. No? Okay, let's ask Dr. Mutawassilian to help.
Thank you. Thank you, Gabe, for the opportunity, Professor Nakufer.
What do you see, Dr. Mutawassilian, here?
The first thing that what grabbed my eyes was about the first molar on the right. Is it right?
Yes, the problem is here. The problem is that we can see a radiolucent area around the mesiobuccal root of the lower first molar of right side.
Yeah.
So what's your suggestion? Extraction, pulpotomy, root canal treatment, hemisection, implants, bone regeneration? Which one? Quick.
You are my professor. I'm ashamed that the respondent.
Don't say that. Okay, carry on. Others can help.
Definitely would not the extraction. I should test the vitality of the tooth to find the reason. And if I want to retain the tooth instead of tooth extraction, probably I will ask a very expert endodontist like you to do the endodontic treatment to prevent the further root absorption to keep the tooth.
On which evidence? On which evidence?
Just now, I have no evidence to present it to you.
But I say that you should do root canal treatment. Why you say that? Dr. Khami, help me. What should I do, Dr. Khami? You are an expert clinician. What should I do? Root canal treatment, extraction, bicuspidization? What should I do?
Okay, so I think this is somehow complicated, but...
Yeah, it is. So ask me some question about the history of this patient. See, when you are going to the evidence, you need to increase your knowledge, put them together, compare with the guidelines. First things that we need to do for this case, and Dr. Mutawassilian is always doing such things, and write a very long report about that to me is sensibility test. And when I test that, the tooth was vital, was sensible. So therefore, I decide to do nothing. And I look at the history of the patient, and I find an impacted premolar was surgically removed, and that tooth was the origin of the resorption, and the tooth was sensible. So I decided to do nothing. And this happened.
Great. Thank you.
Okay.
I told you, my professor, I cannot say anything in front of you.
Okay. I trap you in a very important thing. I trapped you to show you that sometimes by doing nothing, you may end up with a very good result.
Yeah.
So imagine if I did root canal treatment for this case, what happened? Again, healing. And I may say that, oh, I'm a very efficient endodontist by doing the root canal treatment in a very difficult mesial canal. Or if I put some biomaterial inside the mesial canals and show you that, okay, see, this is the regeneration. Yes. So that comes to the control. So we need control. We need to compare some technique, some treatment with some nothing, with doing nothing, and show that this technique can work or not. In medicine, they called it placebo or placebo, by giving the patient sugar, for example, and compare it to antibiotic. Give them sugar in a same capsule that they put, for example, analgesic inside it. I did actually one study myself, and I compare the effect of various yes, that was not antibiotic. That study was about just painkillers, different types of painkillers. I give them different types of painkillers and compare that with sugar. But this type of different types, that includes pyroxicam, diclofenac, naproxen. None of them worked for post-operative pain in endodontics. So for post-operative pain in endodontics, sugar was efficient as naproxen. So what should we do? Do nothing. Do nothing. Sometimes doing nothing is not going to give any harm to the patient. So this is the second message. So don't overgeneralize any case report. Then you may say that, okay, let's have a look to the case series. Because if I did 20 cases, then that may give you more information. Yes, series of cases are more common and may give you some more information, may provide better information. And if you make it larger of patient, particular disease or condition subjected to this treatment can be studied. But the main disadvantage, again, for case series is lack of control group. So I showed you that case to emphasize on the importance of doing nothing. And doing nothing means control group. I'm sure Dr. Shamshiri is very happy because that is the first time some clinician is speaking about doing nothing, comparing to do something. Because we always ask Professor Shamshiri to help us to compare doing something. But then Dr. Shamshiri always asks us, what is a control group? Without control group, this is rubbish. Rubbish is not a good word. It is not rubbish, but in reality it is. Without control,
I'm sorry.
You just say something. Yes, please, go ahead.
Thank you. About the control group, I did do nothing. Sometimes it is not ethical. Is it ethical? For example, giving...
That's a good point. I already mentioned that about Robert Down. I already mentioned different aspects of this story. I'm trying to make this story very simple, but in reality, it is not very simple. And the reason that we need epidemiologists, we need people that they know how to design this type of a study for us is that. Otherwise, we can do it ourselves, but we are not able to do it ourselves. We're just able to do how to ask them to do it for us. Yeah. So we always ask our epidemiologists to help us to design these studies. But now I'm just emphasizing on the importance and the knowledge of that. So if you have the knowledge, then you go and ask Professor Shamshiri to help you to design the study for you. And you know that we don't have enough and adequate information to design the study ourselves because there are a lot of important things that we may overlook them and forget them. So it is important. So for case series, we can utilize them to develop a hypothesis, but we cannot test this hypothesis. I may say that, okay, if you have an open apex, you may use PRF, platelet-rich fibrin. Yes, that's good. It is just to develop my hypothesis. Then you can publish that hypothesis in journals that they are not asking you for control. They're just asking you for the technique, like dental hypothesis. If you want to publish in Journal of Dental Hypothesis, please feel free to send it to us. I'm one of the advisory board or something of that journal as well. So that is very good journal, just because when you think about something and you want to publish that before running the proper study, they are going to publish that for the next generation to run the clinical trial and compare your hypothesis with nothing and show that nothing equal to hypothesis or hypothesis is better than nothing. Then it comes to the significant difference to confidence interval and stuff like that, that help us to understand which way is better. So repair of perforation by MTA is very important. I show you some cases. Look at this case, a perforation that was filled by gutta percha. I removed the gutta percha, I put MTA, and this is the follow-up. Fantastic repair. This is just case series. Can we rely on this case series? You may tell me, okay, you put MTA there. Why MTA? Why nothing? Why something else? If you just clean the canal and leave it empty, that may work as well. There are many studies that show that at least in animal level. I did one study that I cleaned the canal and I filled just the coronal part without obturation and it worked properly. In animal, it worked. Obviously, in human being, in clinical level, I'm not able to do that, as you said, because it is not ethical. But there are some case series and case reports that, for example, a person who forgets to ask for the obturation of the canal came back after 2 years with a very nice healing. Then it comes to some sort of thinking about regeneration, some sort of very brave or very heroic approach to some very difficult cases by doing nothing or by doing very, very minimally invasive treatment. But I cannot show you the success of case series because case series, they don't have control as well as case report. Then it goes to case control studies. I'm almost at the end of my talk because I want actually to finish just at 3 o'clock to give the stage to the next lecturer. Okay, case control studies are a bit better. Why? Because we already have control in them. In case control studies, comparing to cohort studies, especially to prospective cohort studies, they are cheaper. So if we have a hypothesis, after we publish our case series, we may go to the case control studies. And in case control studies, it is easier to run compared to clinical trials or prospective cohorts. We need shorter time for data collection and we can report them quicker. But the problem is because of this shortage of the follow-up, sometimes we don't know what happened over time. And we need very long-term clinical trials or very long-term cohort studies. And the main disadvantage of case control studies is selection bias and recall bias, which we already have that in some of the clinical studies as well. And I'm sure bias is going to be covered in the advanced course, or we already cover some part of that, but we need to go deeper to the different types of bias. And I'm going to use this opportunity and ask Professor Khami, who is the manager of this course, and he is the man behind all of this preparation. And again, I'm going to thank him for that. I'm going to ask him to run also the advanced course for the people that they are very keen to run such studies in the future. And then I will be one of the students of the advanced course for you and Professor Shamshiri as well to learn more. Okay, so another problem of the case control studies is when we look at the hierarchy of evidence, they are again at low level. We cannot overgeneralize and we cannot use the result of a case control studies easily in the clinical level.
It seems that Professor Nekuvar has lost his connection. So I think we should wait, or maybe we can try to call him.
Sorry, all friends and participants, for the interruption that's happened. The connection was interrupted. Professor Nekufar will join us again in a few seconds. Thank you for your patience. We cannot hear you, Professor Nekufar. Please unmute your microphone. Okay, we should share it. Okay. Okay. He unmuted again. Professor Nekufar?
Okay, yeah, that's working now. Sorry, guys, my internet is connected. Okay, I'm sure. Okay, let's make it quicker. Okay, prospective cohort studies comparing to other type of clinical studies somehow give us valuable information on the efficacy of clinical treatment protocols. And also, if you want to find out the causation relation, it can help us as well. In dentistry, we can use it a lot because we don't need to change anything. As a dentist, we can clinically work in our normal manner and we just record everything, put everything together, design a very good study, and then use different types of statistical technique, different multivariate regression, logistic regression, univariate regression, put them together, put this data together, and find out something that we can say, not just correlation, but the causation, which I already discussed in my first lecture. Okay, treatment protocols assigned to different clinics can furthermore be used for comparison purpose. So we can run, for example, a multi-center cohort, and it gives a lot of information, and we need to set up the technique with each other, and also we arrange a follow-up. And when we set the follow-up with each other, we can work on that and publish the data as a higher level of the evidence. Then it goes to the best study design, which is randomized controlled trial. In the randomized controlled trial, if we can run such a things, I mean, in terms of ethics, if we can run such a things, we have a true controlled experiments. It is the one that I already covered. So when I said that do nothing using placebo, using nothing, doing no technique compared to the technique, it gives you a lot of information. And one of the very, very important things in this type of a study is randomization, because then you can use just single variable. In this kind of a study, you can observe the effect of just one variable, compare that with the control group that you don't do nothing in that. And the important thing is you don't decide which one is going to receive the treatment, which one is going to receive nothing, and then you compare them with each other, which is the main powerful advantage of this randomized controlled trial. I think for randomized controlled trial, we need one separate day to discuss about the advantage, disadvantage, limitations, power, importance, technique, and everything. So again, it goes to the advanced course. But this is the powerful tools, as many of the biases that affect non-randomized trial can be eliminated. So in this one, you can eliminate the problems that you already have with others, because in this technique, you already have two groups. It is the example that I told you, comparison of the treatment in one visit comparing to two visits. So whoever comes to your clinic, you randomly send it to each of these two groups, and then you do the treatment and you look at the result, healed or not healed, and then you compare the result with each other and statistically compare them and report them. So I'm going to my last slide now. Thank you very much to stay with me, and sorry for the interruption by the technical issue. This is what we already covered to this level, which was the RCT. And after RCT, the one that we already covered last week, it comes to the second-hand information, or comes to the information that the experts start to filterize them by critically appraised, publication that can be based on the critically appraised individual articles, and then critically appraised topics or mini critically appraised topics, and end up with systematic reviews and go higher to the umbrella review. Thank you very much indeed for staying with me, and I just finished at 3 o'clock. Thank you very much, all of you.
Professor Nekoufar, as before, I highly enjoyed it. It was amazing. I'm so thankful to God that had the opportunity to hearing your speech again. Thank you for taking your time. Best wishes for you. And I hope we have the chance to have other workshop and having your speech again in this type of workshop. Best wishes for you. Professor Khami?
Yes, okay.
Thanks for the opportunity from all of you and Professor Khami.
Okay, thank you. First, I want to just say hello to everybody who is present now in this room. In our last session of our virtual evidence-based dentistry course. And I would like to thank Professor Nekoufar, who was with us from the beginning, from the planning phase of this course, and also as a lecturer in some of our sessions, and we really enjoyed and we learned from him. Like always, I've been Professor Nekoufar's student from more than 20, maybe 24 years ago. So I really enjoyed your lectures. And just I want to say something about you had a slide about placebo. You said something about placebo, and we have the placebo effects also. I can remind that we had a professor in University of Helsinki, Professor Heikki Tuti, and unfortunately he passed away some years ago. But one day he told us that, have you ever used a placebo effect in your clinical practice? And we all said that no, not at all. And he said that yes, you did. Have you ever said to your patients that this antibiotic is very good, this analgesic is a powerful analgesic, so this is a kind of placebo effect that you have used in your clinical practice? Okay, so just to say something about one of your slides. And then thank you very much. I know you are very busy. You are from your surgery now, and you have many patients waiting for you. And I do have something about what you said, and I would like to thank you for that regarding this clinical experience, and also something about shortage of evidence-based dentistry. Today, I will have something about that. So thank you for opening this discussion in your lecture. And we can say goodbye to you if you want to leave us to go to your stations.
Thank you very much indeed. Thanks a lot. And I hope we can carry on discussing such things, because we can learn, all of us, from each other. And to finish what you said that about the placebo effect, I definitely agree with you. One of the good things is I personally have some placebo effect on my patient, because I'm a very smart and very somehow even the color of my clothes can have some placebo effect on my patient. So this is a real example. Obviously, the patients that you have, you don't have this placebo effect on them. I don't know. Do you have any placebo effect, Dr. Khami, or not? I don't know. That's just kidding. And make just this is the sense of humor of me that always working. You know that I admire you always, and I leave you with all the participants and say goodbye to all of you. Thank you very much indeed, and we will be in touch.
Thank you, Professor.
Thank you very much.
I appreciate it. Thank you. Bye-bye.
Thank you.